Hi, good evening, everyone, and welcome to tonight's COVID-19 Community Town Hall, which is presented by UP Health System Portage. We're broadcasting live from the Michigan Tech University campus here. We want to welcome all of our viewers that are joining us on the Zoom webinar and Facebook Live, and the listeners tuning in on 97.7 The Wolf here in Houghton and Q107 over in the Marquette area. Good evening, welcome. My name is Steve Elmer. I'm a college professor, member of the Health Research Institute here at Michigan Tech. In just a few minutes, I'll be joined by our speaker panel, as well as my co-host and colleague, Kelly Kam, who is an epidemiologist. Tonight's topic will focus on COVID-19 and the Omicron surge. We'll do our best to provide information, offer recommendations, and importantly, answer questions that you might have. Just a couple of announcements here before we get started. I want to recognize our two sponsors for the Town Hall series, which include UP Health System Portage and the Michigan Health Endowment Fund. We also appreciate the support of the Health Research Institute. They organize the Town Hall series. Their mission is to support health-focused research, education, training, and outreach here in the rural Upper Peninsula. I also want to recognize the Center for Educational Outreach for helping support our Zoom webinar tonight. The goal of each town hall is to help increase our awareness about COVID-19 and how it impacts our health, the health of our community and society. And to do that tonight, we have a panel of experts here, really an all-star lineup, including clinicians, public health officials, healthcare administrators, graduate students, epidemiologists, and more. I want to remind folks that all of our town hall recordings are public. Tonight is our 23rd town hall, so all of our recordings are archived on our website. So if you missed any of the previous town halls, we've covered a broad range of topics. We're on here every Thursday, the final Thursday of every month. You can view those at any time on our website. That website is mtu.edu/health-research. Once you're on the page, go ahead and click on Town Hall, and you can find out more information about our previous town halls. Also want to remind you that tonight's town hall will be re-aired on ABC 10 this Sunday at 12 p.m. Eastern, so please share that with others that might not be able to make it here tonight. Next, I want to say good evening and Happy New Year to my colleague Kelly Kam, who once again is an epidemiologist. She's a member of the Health Research Institute and has really been instrumental in helping advocate for public health here on our campus and in the community. So Kelly, welcome back. Good to be working with you. And can you tell us a little bit about who's here tonight and what should we expect?
Absolutely. Well, thank you for having me again here. So we have, as Steve mentioned, we have a panel of a variety of different individuals here to talk to us about the Omicron surge. We're going to start off with Dr. Robert Van Houw, who is the medical director for two of our health districts here in the Upper Peninsula, the Western UP Health District Health Department, see if I get that right, and which covers our 5-county region, as well as the Dickinson Iron Health District, which covers an additional 2 counties. And then we have Don Simula, who's the CEO of Upper Great Lakes Family Health Center, so one of our major providers for our healthcare up here in the area, to talk about the surge and the stress on the healthcare systems. Following Don, we have Luke Wislick, who is a PA from a physician's assistant at Aspirus in Ironwood, so one of our other major providers of healthcare up here. And Luke is a clinician who's going to be talking to us about the acute care perspective and how the surge has been affecting that perspective. Following Luke, we have Dr. Jennifer Becker, who is an associate professor here at Michigan Tech. She is in the Department of Civil, Environmental, and Geospatial Engineering. Apparently here at Tech, we do not believe in short names for our departments, so we have nice long ones. And Dr. Becker has been working for more than 2 years now on the wastewater based monitoring of COVID-19. So she'll be talking about her experiences on that. And our final speaker will be Ashley Hawk, who is a doctoral student in the department that Steve and I both work in the kinesiology and integrative physiology. And Ashley will be talking about health information and misinformation and the role that students can play and have played in addressing that.
Thanks for that overview, Kelly. I just want to remind our listeners and viewers, if you do have a question tonight, you can send those in 2 ways. For the folks and audience members that are on Zoom, you can send those in using the Q&A button at the bottom. And the other way is to email us at townhall2020@mtu.edu. We'll do our best to direct our questions and weave those in as we move through the town hall. So Kelly, I'm going to turn it back to you. Our last town hall was, it seemed like months ago. It was December 2nd. Just before we took a little break for the holidays. We just started talking about Omicron then, And fast forward several weeks and things look very different. So with that in mind, can you help us kick off our discussion and really framing how things look currently here in our community and state and even nationally?
Sure. So I think the email address actually says a little bit about it. Is when we started this as Town Hall 2020, there was hope that we wouldn't be here 2 to 3 years later, still talking about the same thing, and yet here we are. And as you mentioned, so at the time of the beginning of December of last year, nationwide, we were kind of at that kind of a low lull. We were stabilizing after that fall peak. And when we looked at the types of variants that we had, 99% of our sequenced cases at that time nationwide were Delta. Now, by mid-December, just a couple of weeks later, about 40% of our sequenced cases nationwide were Omicron, and now we are seeing more than 99% of our cases are Omicron. So Omicron was very quick to kind of take over from Delta. And what we're seeing in addition to that is that Omicron is much more infectious. So we have, compared to where we were at the beginning of December, our average 7-day, our daily, the average of the 7-day average daily cases, get that all out there. It's 7 times what it was back in December. So we have significantly more cases that we are seeing. And what that means, in addition to, all of what we're going to talk about at this time, is that one of the really big concerns that we have with this is that even if Omicron is, as we're seeing, is less severe, and we have more options than we had, say, a year ago with vaccines and treatments available, the bulk of these numbers, this large number, means that our raw numbers of severe infections and hospitalizations and deaths are going to be high, and that's what we're seeing. So currently in the United States, we're seeing nearly 2,300 deaths every day when we look at it for the 7-day average, compared to 1,900 deaths at that peak last fall, even though there were fewer cases at that time, or because there were fewer cases, even though the severity was higher. And so that's what we really have to be concerned about, is this isn't, if it's mild for one person, it's not necessarily going to be mild for everybody. And when we have these huge numbers of cases, we are going to continue to see these deaths and these severe cases. But we do know that vaccines work, even with Omicron. Getting a vaccine and getting the booster really does protect you and reduce both your risk of getting infected and your risk of hospitalization and or death. Just briefly to compare where we were and where we are now in our local county. So Houghton County, we're currently at 1,437 cases per 100,000 people. Where we were in early December was significantly lower, around 700 to 800. So quite a bit higher than we were. And we are still continuing to see deaths. So here in the most recent data, and Dr. Van Houw can speak to this a little bit more, but the most recent deaths we've had 10 deaths recently here in the Western UP Health Department district area. So we are continuing to see these deaths.
Great, thanks, Kelly. And one quick question for you here, as we're already getting questions via email. There's been a lot of updates from the CDC, including updates and guidelines for masks. I'm just wondering if you can touch on those. What has changed since a couple of months ago, and what do people need to know about the K95, N95 mask? If you could just touch on that briefly.
Sure. So we do know that masks do reduce infections. It protects not only if I was infected, it protects it from spreading the virus. It also will protect the person who's wearing it. So having both people wearing masks absolutely helps. Anywhere that there's considered high transmission, which is more than 100 cases per 100,000, we're at that 1,400, so we are definitely in the high cases. CDC guidance is to wear masks at any indoor area. As far as the type of mask, we do know that the better you can get for the mask, the better off you'll be. It does mean that you do need to wear it. So there's a couple different kind of caveats on there. You want the best filtering mask. So a KN95 is going to be better than a cloth mask, but you want the best mask in terms of filtering that fits you the best and that you will wear properly. So if you have a KN95 that doesn't fit very well, that may not be better than a well-fitting cloth mask that has multiple layers in it. Same as that if you're going to keep pulling a KN95 mask down so it's not covering your mouth and nose, then wearing something that you can tolerate and wear it properly is going to be better. So the best fitting, most filtering that you can get that you will be able to wear. So it starts from the top as an N95, which has to be fit, a KN95, a cloth mask with multiple, or a surgical mask in there, or a medical grade mask, and then a cloth mask with multiple layers on that.
Great. Kelly, we will circle back and bring you in a little bit further on. I want to keep us moving on to the next speaker. We're going to really welcome back Dr. Robert Van Houw, who's the medical director here in the Western Upper Peninsula Health Department District. So Dr. Van Houw, good to see you. I know you were back here in, it would have been late August when we were talking about dealing with Delta. And so again, while things have changed, but importantly, welcome back. We do appreciate your time tonight. We'll turn it over to you to provide some more public health guidance for our Upper Peninsula here.
Well, I don't know if it's a good thing if you have me back, because every time there's a surge after I'm on the show. But one of the things that we see with the surges in the Upper Peninsula is that there's a delay from when the surge happens in the Lower Peninsula and the rest of the country, and then we see it later here. Unfortunately, Delta was not completely gone when Omicron came on top of it. And some of the deaths that we're seeing currently are still from the Delta surge, because there's a delay from when you get sick and how it takes a while for you to get in the ICU, and it takes even longer before there's a mortality associated with it. We are having by far the highest number and the highest rate of cases right now at any time during the pandemic. Not clear if it's peaked yet or not, a little too soon to tell. It may have peaked. But one of the things you have to think about is that the peak means there's going to be as many cases on the way down as there were on the way up. And there were a lot of cases on the way up. The other thing that we're seeing is that the Omicron seems to be hitting children harder than it is the previous variants did. So we're seeing more children needing to be hospitalized with this. A lot of people are saying that the Omicron is just a mild cold, like a mild cold, but that's if you've had all of your vaccinations and your booster, it might be like a mild cold. If you haven't been vaccinated, you can get hit pretty hard with this. And we are seeing severe hospitalizations, ICU stays, and deaths associated with Omicron. So it's nothing to take, you need to take it seriously. There are some treatments out there for people who have come down with the infection and are expected or not hospitalized yet, but are at high risk for hospitalization. There is some monoclonal antibody that does work on the Omicron variant, but it's in short supply. There's also some oral antiviral medications, but there's a limited supply of those, and there's very limited people who qualify to get that medication at this point. Going forward, it's hard to know what's going to happen. There may be another variant on the horizon. It's always hard to say what exactly they're going to do. The next variant could be more contagious and provide a much tougher time for those who get infected with it. So I don't think it's hard to predict what's going to happen. My crystal ball stopped working years ago, so I don't consult it anymore.
Dr. Van Houw, thanks for getting us started here. A couple of questions for you. We talked about some of the updated CDC guidelines. If folks are exposed or they do test positive, can you remind us what are the guidelines right now for quarantine and isolation?
Yeah, it gets a little confusing. Isolation is for those people who test positive for the illness. So if they have a positive test either at home or at the doctor's office, then they're supposed to stay at home for 5 days. And then if they are fever-free for 24 hours, they can come out of staying at home. And it's recommended that they wear a nice fitting mask for another 5 days. Okay. If you test positive and you don't have any symptoms, then you isolate for 5 days. Quarantine is if you were a close contact of someone who's infected, and you quarantine for 5 days if you've not been fully vaccinated and haven't had your boosters. If you have had your boosters, you don't need to quarantine. If you've had a documented infection in the last 90 days, you don't need to quarantine, but they recommend that if you have been exposed, which is more than 15 minutes within 6 feet over a 24-hour time period, that you need to wear a mask for 10 days.
Dr. Van Hal, one more question here. I've been hearing this a lot in the news, and this has come in here as well. Folks asking, given the more mild disease that we're seeing with Omicron, should they go out and get COVID and get it over with, so to speak? And can you just comment on that?
Some people have done that and died. There's been some high-profile cases of people doing that. One of the things that happens is that we're finding that the natural immunity from the infection is not as strong as if you get the vaccination. If you have had the infection before and you get vaccinated, you're much better off than if you hadn't been vaccinated. It's really a crapshoot on whether you're going to have severe illness or not. If you've not been vaccinated, the chances of you needing to be hospitalized is 17 times higher. If you haven't been vaccinated, your odds of dying are 20 times higher. So, it goes back to, Dirty Harry. Do I feel lucky? I don't. It's just you're taking a chance, a big chance of having a complicated infection and possible long-term side effects from the infection if you're not vaccinated.
I'm going to do one more question, and this could be both for Dr. Van Hal and Kelly, who just spoke. There's a question that came in via email here just about universal masking in schools. And from a public health standpoint, I know there's certainly a lot of questions about this, but what advice or what perspective can you provide with universal masking for schools and protecting kids? And I think they're getting at here those younger kids that may not be able to get vaccinated yet.
Well, when they've compared school districts that had universal masking versus those that didn't, there were fewer infections in the districts that had universal masking.
And we also have to remember, we're looking at what our vaccination rates are where we live. And certainly in those younger age groups, vaccination rates are not as high as we would like to see them. And so somebody coming to school that might be infected, we have to remember that people are infectious for at least 2 to 3 days prior to them getting sick. And that's when we look at that. It's not just them getting sick. They're exposing a lot of other people who might have very severe illness as well.
And by wearing a mask, they decrease their risk of spreading it to someone else.
Great, thank you both. Just want to pause here for just a second and welcome any new viewers or listeners that might be tuning in, especially those out on 97.7 The Wolf or Q107. We're here for the UP COVID-19 Community Town Hall, which is presented by UP Health System Portage. We're talking to a panel of experts tonight on all things COVID-19 and dealing with the Omicron surge. We've heard from an epidemiologist, Kelly Kam, and the medical director, Dr. Robert Van Hal from the Western Upper Peninsula Health Department. We're going to continue on. Our next speaker is Don Simila, who is the CEO of Upper Great Lakes Family Health Center. So Don, good to be connecting with you virtually. Thanks for coming on, and we're grateful for your time. I'll turn it over to you to talk a little bit more about the stress on the healthcare system here in the UP.
Well, thank you, Steve, and hello, everybody. Thank you for having me on tonight. I appreciate the opportunity to support your town hall information sessions. When you emailed me and suggested I join your call, I thought, well, sure, why not? I can speak to the impact, the pandemic has had on our communities and our health systems. There's a lot of information from across the country, local data on the stress that the healthcare system and providers are experiencing, but then everyone really cannot help but hear something about the COVID pandemic every day in the press, on the radio, television. With all due respect to my fellow panelists tonight that have and will share with you the numbers, I will not. So we all hear the numbers, the data, the number of COVID patients in the hospital, the number of new COVID cases in the community, the number of deaths. At times it's hard not to become data drunk. At this point, after 2 years of numbers, it seems hard to pay attention to them. So I thought, how can I convey this message in a way that we might all relate to? So I'm going to take a little different path here. So I came up with a Keweenaw analogy, and if you will allow me, let me give it a try. So first, let me start out by saying that all of our healthcare providers across the Upper Peninsula have been remarkable in their continued commitment to the health and well-being of our community. We're blessed, I think, to have so many of our community members choose to serve, from EMS, public health, our hospitals, nursing homes, health centers, universities, and not to mention many of our public schools that have had to learn infection control on the fly. So here we are at the end of January in the Keweenaw. We're about a third of the way through our normal winter. Our winter starts generally fairly slowly, late October, mid-November, 6 inches of snow here and there, a warm up, it melts, a little more snow. Sooner or later, the weather gets colder. The snow begins to accumulate. As seasoned Upers, those of us who've been here most of our lives or all of our lives, we shovel, we scoop, we snow blow, we plow, we move the snow from the drive and the walks to the side of the yard or the back lot. The snow, it just keeps coming. 12 inches, 10 inches, day in, day out. Soon the banks begin to get larger. The streets start to narrow. The snow keeps coming. At some point, we start running out of room to put the snow. There's no room in the yard. The back lot is full. The snow blower can't shoot it high enough to get it over the bank. Then left with few alternatives, the snow starts to get pushed out into the street. We've all done it. We've all had it happen to us. The streets keep getting narrower. The neighbor upstream, on the upstream side of your driveway, puts the snow on the road. It happens once, it's an inconvenience, you shrug it off. The snow keeps coming. Snow upstream from your driveway is now in your driveway day after day. Soon it becomes more than an inconvenience. It becomes a frustration, more than annoyance. You might have words with your neighbor. Inevitably, the city or the county comes along with a really big blower to widen the streets. And it's a thank goodness. Now all that snow's in your front yard. And we've all seen them. The signs go up, blow no snow. The city and the county crews get yelled at. The snow keeps coming. We can count on that. We can also count on the winter running its course. We know it will only last so long. We all look forward to February or March thaw. We get a reprieve. Soon winter will be over. Summer's coming. It will melt. Well, COVID has been relentless for 2 years. We wonder if it'll ever be over. Our healthcare staff or our healthcare teams have been shoveling and keeping the system of care open in spite of the persistent and relentless onslaught of cases. There's only so much room to put patients, only so many staff to provide care. They've been working overtime, working short staff because a coworker is sick or they are home taking care of a family member that is sick. Supplies run low, beds are full. There's only so much room. And then someone yells at them out of frustration because the system is overtaxed. It's not the healthcare team member's fault. They do all they can to care for the community. Locally, we as a community of healthcare providers have managed through this thus far very well by collaborating, sharing a few resources that we can with one another. But when you have, say, only 4 OR nurses and 2 are home sick, it's hard to provide the full complement of care that we always provided. Our large referral centers get full. Some are what we might call expected and routine cases, heart cases, trauma cases, emergency deliveries. Our systems are designed and built to handle those. When you add mass casualties from a pandemic, the system gets taxed. There's not room for an expected heart case at the referral center. So those patients get boarded in an emergency department at a local hospital, sometimes for days until there's enough room or staff and a bed available to transfer that patient. That is, of course, if our EMS system has adequate staffing to do the transfer, and also keep EMTs and EMS teams available in the local community to handle the expected cases. So on a national, state, and local level, our healthcare system has been built to handle our current population and expected healthcare needs. Add in a pandemic, and we simply don't have the capacity to handle mass casualties across the system. From routine outpatient care for chronic conditions to emergency room services, OR procedures to nursing homes. Each of us as a community need to assume some responsibility to do all we can to reduce the rates of infection. We have the tools to reduce the stress on the system. Some of us opt for immunization, some of us don't. Immunization is our best defense, but we can all practice infection control. Wash your hands, social distance, wear a mask, and together we can get through this. So for now, we just keep shoveling, but it helps if we can all be a part of the solution. So be kind, be patient, and let's all do our part.
Thank you, Don, for that analogy and for giving us the update. There is a question here. The community member is saying, you know, I am hesitant to come in, whether it's the hospital or my local clinic for routine medical care. I'm hesitant to come in. What advice would you have for people that need care, but just, you know, right now are opting not to come in?
Well, I can say it, you know, across our healthcare system, our healthcare providers have been practicing infection control for generations. So, you know, we're all trained to do this. I tell my staff on a daily basis that our healthcare clinics and our and all of our sites are probably the safest, most sanitary places that they can be. You know, we practice universal masking. We're continuously cleaning in our environment. We social distance. Everybody's trained to handle infectious disease. So COVID is not the first infectious disease that we've had to encounter in the healthcare system. We deal with it every day: C. diff, influenza, a variety of other infectious diseases that we've all been accustomed to handling. And our healthcare systems are safe and an appropriate place to be.
Well, Don, we appreciate your update. I think this is a good time to transition to our next speaker. We're going to welcome in Luke. Luke, I had a note here, Wislick, got the last name, who is a physician assistant with Aspirus over in their Ironwood clinic. So Luke, welcome back virtually to campus. We know that you have connections here as a graduate a number of years ago. And thanks for coming on. Tell us a little bit more from an acute care standpoint and what you're seeing interacting with community members and patients on a daily basis.
Yeah, thanks for having me on. So really what the message that we wanted to put forward was, you know, there seems to be a lot of people, again, that think that COVID, or especially the Omicron variant, isn't all that bad. It's, you know, just like the common cold. But what people need to keep in mind that we have a significant amount of elderly patients in the UP, and also people with underlying medical conditions. And so even if your symptoms are mild, we're still seeing a number of people coming into the ER, coming into our respiratory clinics, coming into our walk-in clinics, just simply for this fact that they don't feel good, which is understandable, right? You know, in the mild cases, you know, there's not much we can do for that other than, you know, offer reassurance, you know, that kind of stuff. But keep in mind that we also have all these other people with other underlying medical conditions that we have to take care of. And so when we keep having these surges over and over and over and over, it's a huge strain. And most of the hospitals and clinics here in the UP are considered, the clinics anyway, are considered rural health clinics, and the hospitals are considered critical access hospitals. And there are designations for that in terms of the amount of bed space and providers that you can have. So what ends up happening is that, you know, even if you hear that, oh, Ironwood only has, you know, 4 or 5, you know, COVID patients up on their floor, keep in mind that our census is typically only between, you know, 12 and 16 people. So now you have a quarter to half of your patient census is being attributable to one disease process. And we know, and for the people that think that this is all made up, and and they don't believe in the vaccine, stuff like that. Well, the data says otherwise. It's very, very effective at keeping people out of the hospital. And if you think that the CDC is lying about this, I mean, you can just look at the Aspirus data. They put that out, once a week, and I see it firsthand. Ever since the vaccines were introduced, 70 to 80% of the people that are hospitalized are unvaccinated. Okay, so it does help. It does help. And so that's what, people just need to keep in mind. What we really need, though, for most people, especially those that have mild symptoms, they can still get up, move around, they're eating and drinking okay. Rather than running, to your ER or to your, respiratory clinic or the walk-in clinic, please consider doing virtual visits if you want to be seen. Again, because this is a viral illness, there's not much we do therapeutic-wise. There are some medications, and I'll touch on that in a little bit, that are now available. But other than that, there's not a whole lot we can do. But the people that we do want to have come in and be evaluated are those with moderate to severe symptoms. They're having, chest pain, feelings of palpitations. They're not able to eat or drink. They're really weak and fatigued. People with underlying lung conditions like COPD, especially. We have a significant COPD population here in the UP. Those we want to come in. We want those people to come in immediately, be evaluated, so we can get your vitals. And then if there's an adjunct therapy that you qualify for, then we can get you, we can get you started on that. Otherwise, there's not a whole lot, like I said, that we can do. And so for the adjunct therapies that we have available now, one is the Paxlovid, which is from Pfizer. That's actually a conjugate antiviral. There's two different medications that you would take on that. Both, or one of them blocks the viral replication process, and then the other one, medication that you would take, inhibits the breakdown of it. And there's molnupiravir, which is another one. That one you have to be 18 or older, and the Paxlovid is 12 or older. And kind of like what Don was saying, I think if we all come together and kind of work together, we can eventually get through this. But our healthcare system here just we're not set up to keep having these huge surges over and over and over. And that's why you're seeing all this burnout and people leaving. And this isn't just a problem with the vaccine mandates and stuff like that. This is a problem in healthcare in terms of shortages and stuff like that, well before COVID even started. So kind of like what Don was saying, as long as we can kind of work together and do your part, whether that's wearing a mask, staying home if you're not feeling good, considering getting a vaccine, don't go to these huge parties and stuff like that, because we had several around Christmas and Thanksgiving where people went to those gatherings that were symptomatic, and they ended up coming in to the ER about 10 to 14 days later, and you end up getting just like almost like these micro surges that end up forming. Then keep in mind, with these small hospitals that we have here, it doesn't take much to overwhelm us, especially in the winter months here in the UP. We have a lot of out-of-towners here. We have a ton of skiers and snowmobilers. Even for those people that like to do those activities locally, trying to get you to a larger center if you're critically injured right now it's not happening. It's maybe a little bit better the last 10 days or so. But that golden hour of trauma, getting in a helicopter to Wausau or Duluth or Marquette or Green Bay, that's not happening. If you're lucky, we can get you there the same day, but otherwise it's the next day. And we're at the point now, even here in the UP, just like what you hear in the news, people are dying in our ER because we can't get you to our definitive care, and that's happened to me personally. And it takes a toll on, and it just gets to the point where you get super frustrated because it seems like people just don't take it serious. And again, that it impacts us all in one way or the other, even if you don't believe it.
Luke, going to jump in here with a question. Thank you for your update there. So if folks aren't feeling well, how do you know if it's a cold, flu, COVID? Just can you give us some guidance, or do we just need to get tested automatically?
So typically with COVID, and there's a lot of overlap too, because we have a ton of RSV. We also have a lot of influenza that's also going with this, and they all overlap. Typically with COVID symptoms, though, it'll be a little bit more than the common cold, because you'll have profound fatigue, a lot of weakness, and then fever. Typically the common cold won't give you 102, 103 degree fever where you can't even get up out of bed. Typically at that point, you want to wait at least 3 to 5 days, because if you just come in and run in right away, get tested, there is a small chance that we can miss it just because you're out of that viral replication window. So your best bet is to isolate for 3 to 5 days. If you're still feeling ill at that point, then we want to come in and get tested. If that's all you're looking for, again, please refrain from using the ER for that. We have tons of outpatient services where you can get a test, whether that's Walgreens, Walmart. Here in Ironwood, Monday through Friday, we have outpatient testing that is set up where people can just show up and do a self swab. And usually our turnaround on that is about 24 hours.
Luke, one more question for you. This is a really good question. I've seen this come up a couple times. This is through our Zoom platform here. It says, if a person's vaccinated but not boosted yet and they get Omicron, how long should they wait before then getting the booster?
Normally, it's about 90 days. There have been some instances where people have actually gotten the booster or even their second dose of vaccine and they were asymptomatic. And you get, the chance of you dying or anything is very, very low. But typically, we want to wait about 90 days just for that inflammatory response of the immune system to come down before you get that booster. Otherwise, like I said, the chance of it causing a great deal of harm, very low. You're not going to feel really good.
Great. We're a little over halfway through our UP COVID-19 Community Town Hall. I just want to take a brief minute and recognize our sponsors. We really appreciate the support of UP Health System Portage and the Michigan Health Endowment Fund. We're here with a panel of experts, including public health officials, clinicians, and we're hearing really about all things COVID-19 here. We're going to keep things moving, but before we do, I just want to check in with Kelly. Kelly, what has stood out so far on the first half of our town hall? And I think there might even be another question for you here, so I'll give you the platform.
Yeah, absolutely. I think remembering that everybody has been doing this for a really long time. I know I speak to everybody, and I'm sure everyone on this panel has spoken with people too, where everybody's going, I'm just sick of this. I want to be done with it. So do we. We all want to be done with it, and yet we can't be because it's not done with us yet. And so remembering that, I think what Don mentioned, be aware of that, of being kind to other people, being recognized that we're doing our jobs and trying to protect the health of the community here.
Great, thank you, Kelly. And one of the things that did come up here too, Luke mentioned, where can you get a test? I also wanted to remind folks there is that website, covidtest.gov, where you can order home tests. Simply just enter in your information and you'll get that in the via the U.S. Postal Service. Next, we're going to move forward and welcome in Professor Jennifer Becker, who is a professor here in Civil, Environmental, and Geospatial Engineering. I hope I got that right, Dr. Becker. Welcome back. I know you've been on the town hall before. You're going to tell us a little bit more about your work and your efforts and what your team is doing to monitor COVID-19 through the wastewater-based monitoring. I'm going to go ahead and turn it over to you. And I know you have a couple of infographic slides. I will pull those up here for our audience. So Dr. Becker, thanks for being here and take it away.
Great. Thanks so much for having me back. This continues to be a fascinating area of work, although it's, as Kelly mentioned, Dr. Cam mentioned, it's an area that we all would like to put behind us. But I'm happy to talk a little bit about the work that we're doing on monitoring COVID-19, really SARS-CoV-2, which is the name of the virus that causes COVID-19 in wastewater. And this idea of using wastewater to monitor illnesses or other factors that impact public health is not really a new one, but really in the last 2 years, we've just seen it really take off. So before the pandemic, we had maybe a couple of communities in the United States and elsewhere in the world that were using wastewater-based monitoring or epidemiology to study public health trends, and a couple of businesses. But now we're really seeing many, many communities throughout the United States and some universities like Michigan Tech employing this tool as well. And I want to emphasize that this idea of wastewater-based monitoring really doesn't substitute for public health monitoring of COVID cases, but it complements it. So that's just illustrated here in this graphic. We have our public health officials who are collecting data on the number of COVID cases. Those are the results of COVID tests, diagnostic tests. And then we can couple that with the information we get on viral loads in the wastewater to get a good understanding of the emergence, the patterns of illness within communities. In other words, epidemiology. And hopefully this information will help us, limit the spread of disease and prepare for future outbreaks or pandemics. Next slide, please. So just for our listeners, our viewers to understand, there's a couple of really key steps that occur in wastewater-based monitoring. So in the upper left corner of this graphic, we have a representation of a population. This could be the residents in a dormitory or a nursing home or of an entire community like the Houghton Hancock region. The red individuals represent people who are infected with SARS-CoV-2, have COVID-19, and those individuals are going to shed some of the virus particles in their feces. And of course, that fecal matter is going to find its way into our sewer system. And so then when we have people collecting samples from the sewer system, the sewer shed, we call it, either by putting samplers down into manholes or collecting samples directly at the wastewater treatment plant, we can take those wastewater samples back to the lab and then process them in a way that allows us to quantify the virus. And so one thing that's really important to understand is that the virus concentrations in wastewater are very low. So this is different from the virus concentrations in maybe a specimen that's collected from your nasal passages. So we need to concentrate that virus, and then we pull out the genetic material associated with that virus, and then we quantify it. So the last two steps are similar to what happens in when you get a COVID test. They also, the technicians there will extract the viral genetic material from your specimen, and then they're just going to really look for the presence or absence of the virus. Whereas in wastewater-based epidemiology, we actually want to quantify it. So we're going to look at, the absolute concentration of the virus, and we can sample a location over time, or we can sample maybe within a community at different locations to get it, so we can get a picture of virus levels temporally and spatially. So you might ask, why go through all this trouble? Why sample the wastewater? It's a pain, especially right now. Manholes get frozen shut. Why not just get information on the spread of the disease by looking at those case numbers? Well, one important reason is that people actually start shedding the virus in their feces before they develop symptoms. So we kind of get a little bit of a head start. We get a little advance notice that maybe we're seeing a micro surge happening. And also importantly, it's generally the emergence of symptoms that prompts people to go get a test, whether it's a PCR test, at a Walgreens or Walmart, or a home test. So we can get information on COVID-19 levels without relying on individuals getting those tests or perhaps reporting them. So those home test results are generally not reported officially. This is a little bit of a tedious process. So we have people going out and collecting the samples, and then the steps of concentrating and extracting them and doing PCR. It's about a 5-hour process. But when we sample and perform these steps on wastewater, we're getting information on, the number of infections within an entire population. We're not having to do this for each individual. So it can be a quite cost-effective way of getting information on disease levels within a population. So next slide, please. So really quickly, if we sample a given manhole, a wastewater flow, for example, from a dormitory like we're doing at Michigan Tech, we do it at regular intervals. We can get information on, again, the emergence of the illness within a residence hall or a nursing home or community. And hopefully we also see the decline. We've seen that many times at Michigan Tech, where we've been then confident that we don't have infections within a dorm. We've seen it in our communities where, like with the Delta variant, that COVID was starting to really decline. We can also, as I said, get information on the spatial distribution of illness. So we might collect samples at the local wastewater treatment plant. We, again, maybe see an increase in virus levels, and we want to find out, where are people sick? Are these individuals at a nursing home? So we can go up into the sewer shed, collect samples from different manholes, try to pinpoint those hot spots and exposure sites. And then importantly, if we identify hot spots or exposure sites, we can encourage testing and make sure we disseminate information about testing and other resources to individuals who may have been in those hot spots or exposure sites. Next slide, please. So I wanted to just show a little bit of data that we collected. It looks like some of my numbers didn't show up quite right, but basically you're looking at data that was collected over a 10-month period. And so what we see in the top graph is cumulative COVID-19 cases in the entire Houghton County. So this is just the accumulation. So when we were back in June of 2020, we had maybe 1 or 2 cases. And then by spring of 2021, we had considerably more, around 2,500. Again, all of Houghton County, not all of these people were creating wastewater that was being treated at the Houghton wastewater treatment plant, Portage Lake Water and Sewer Authority. And in the bottom graph, I show the concentration of SARS-CoV-2 in wastewater, the wastewater flowing into that treatment plant there on our Portage Waterway, QNL Waterway. And you see there that, you know, in June and July, August of 2020, we saw no virus at the wastewater treatment plant. And then around September, when levels started increasing in the county, we started detecting it regularly in the influent to the wastewater treatment plant. And if you would just advance, Steve, we'll look at the data presented a little bit differently. So now the top graph represents the active cases that were reported by the Western UP Health Department during that time. And again, we didn't see active cases in the summer of 2020, but they sure started showing up in fall of 2020 and throughout the winter and spring. And you see that in general, the number of active cases in Houghton County correlated pretty well with the concentrations of SARS-CoV-2 that we detected in the wastewater plant. Again, we don't expect exact correlation because there's many more people in Houghton County than those who are contributing to the wastewater flows coming into Portage Lake Water and Sewer Authority, but it gives you an idea of how these data sets complement each other. Next slide, please. So here at Michigan Tech, I've been able to enlist quite a few students. They're really excited about being part of this project where we collect wastewater samples from 5 residence halls. This year we've been doing it 3 times per week, and we've been basically monitoring SARS-CoV-2 levels in wastewater during the academic year since September of 2020. And this information is being used to provide nearly real-time information to our COVID-19 response team at Michigan Tech, and just generally inform the campus community about, you know, the prevalence of COVID-19 on campus. And this work is being funded by our COVID-19 response team. So again, if I get information on a Monday that suddenly we have high viral loads in the wastewater flow coming out of a residence hall, I pass that information on to our COVID-19 response team. They pass it on to the residence hall folks, and they encourage students to go out and get tested. And I think this has been really successful. I think the students, like the rest of us, are kind of tired. We're kind of starting to tune out this drumbeat of COVID cases are rising. But when you get alerted to the fact that, hey, we detected it in the wastewater from your residence hall, maybe they have a sniffle, it does tend to encourage them to go out and get a test and find out whether they're infected. And it also helps our COVID response team also, you know, be prepared in terms of providing facilities for folks to isolate in. So it's been a very useful part of our effort to keep our campus community safe. And what you see over here on the right is just 2 of the students when we were first getting established in fall of 2020, late summer, figuring out how we were going to do our sampling, identifying our locations where we could collect flows that really discreetly give us information on individual residence halls. Next slide, please. So one of the, I think, more exciting developments in the last few months has really been the use of wastewater monitoring to detect the emergence of not just SARS-CoV-2 in general, those original strains that we were dealing with in the beginning of 2020, but also patterns of infections with some of the variants. So as we all know by now, that when we have individuals infected with SARS-CoV-2 or other pathogens, other viruses, for example, those viruses have to replicate themselves. And as a part of that process, they're going to be making copies of their genetic material. And sometimes in that copying process, mistakes are made, and those are mutations. And some mutations are not successful. They don't allow the virus to continue replicating or infecting individuals, and they die out. Other mutations really make the viruses more fit, better able to infect, or maybe more virulent. And those continue to spread then within communities. And variants that have specific mutations can also continue to mutate. We've seen that with like Delta and Delta Plus and so forth. And so again, we want information on the spread of those variants within communities, because as we've seen, others have mentioned tonight, Omicron is more infectious than perhaps Delta, but Delta had very severe effects. And as we heard, all variants can cause severe illness in certain individuals. So let's just look over in the left-hand corner of this graphic. We see a representation of the SARS-CoV-2 virus. And we're all used to seeing those spike proteins. But in the center of that graphic, you see the virion structure or the genome. That's the entire genetic information contained within the virus. And that genetic information tells the virus how to make all of those different structures, the spike proteins, the membrane, the envelope, the nucleocapsid. And so when you get a COVID test here in the United States, what they're looking for is the part of that genetic information or genome that encodes a nucleocapsid. We call those the N targets. And so we can have mutations or mistakes in much of that genome. And what we see at the top of the graph is basically a map of the genetic information contained in that genome. And so over on the right, you see that a portion of that genome encodes the spike proteins and the nucleocapsid and the membrane and so forth. And so, for example, Omicron contains something like 30 mutations just within this genetic sequence that encodes the spike proteins. So we can design assays that will be complementary to only certain mutations. So when you go get a COVID test, we use a technique called PCR to detect whether the SARS-CoV-2 is present in your specimen. And so we can do a qPCR assay that will only work if the specific mutation is there. So our PCR primers and probes will be complementary to, or basically match, those mutations. So we can distinguish and determine whether the SARS-CoV-2 virus is a Delta variant or Omicron. It requires a bit extra work, but we can do it. And there are groups within the country that are using this PCR-based approach to monitor for different variants within the wastewater. And of course, we can also take that genetic material that we've extracted from wastewater and sequence it and determine if those mutations are present. So there are two different approaches for monitoring for the presence of variants within wastewater. So that's all I have for today. I'd be happy to take questions from our audience if there are any.
I have to remind myself to unmute. Thank you, Dr. Becker. Fascinating work, and it's great to have you back on to see how things have progressed since the last town hall. For the sake of time, I know we have one more speaker to go. I want to make sure Ashley's got a few minutes here. So I will turn it over to Ashley. I know Ashley's a graduate student in our integrative physiology and kinesiology program. So Ashley, welcome to the town hall. You're going to touch a little bit on health information. So I'll turn it over to you, give you the last couple of minutes. We'll go from there.
All right. Thank you, Dr. Elmer. So again, I'm just going to briefly talk about the importance of sharing health information in regards to COVID-19. So over the last 2 years, our understanding of COVID-19 has unfolded in real time and continues to evolve daily. With so much new information coming out, it can be difficult to keep up with what's current and accurate among everything that's out there. So unfortunately, we've also seen an influx of health misinformation, which is information that's false or misleading. And this has actually led to the World Health Organization classifying this increase of misinformation as an infodemic. Sometimes misinformation is shared intentionally and or maliciously, but many people who share are often just voicing concerns they might have or seeking answers to questions they have. They aren't sharing to intentionally misinform others. Regardless, sharing misinformation is costly, literally. Since May 2021, misinformation is estimated to have cost the US between $50 and $300 million worth of harm each day. As a result, the US Surgeon General, Dr. Murthy, has called on all Americans, including educators and universities, to do our part in helping build a healthy information environment. So in response to this call to action by Dr. Murthy, my fellow graduate students and I are trying to do our part in providing reliable COVID-19 information to the Michigan Tech campus and surrounding communities. We've come up with a few ways to do this. First, with the help of Dr. Elmer and Dr. Cam, we've been distributing a bi-monthly COVID-19 newsletter to the KIP department. In this newsletter, we highlight the current case trends in Michigan and in Houghton County. We share a relevant research study of the week. We share a healthy living tip of the week, and then strategies on how to find correct information, focusing on reliable websites that have .gov, .edu, or .org in them. We've also updated our department website to include COVID-19 resources, such as where to get tested on or off campus. And then lastly, we created a short 2-minute video that reiterates the continued severity of the virus, ways to keep yourself and your community safe, and then what to do if you're exposed or test positive for COVID-19. So I just want to end quick with some easy things that we can all do to help with our part in building a healthier information environment. First would be to get your information from credible sources and from those with health credentials, such as public health experts, your primary care provider, and again, websites that end in .gov, .edu, or .org. Second would be to use social media with caution. There are some legitimate sources of information on social media, like the Copper Country Strong and State of Michigan Facebook pages, but think twice and do just a quick fact check before hitting share. And then lastly, talk with your family and friends about where they're getting their health information from. And if they do list a source that maybe is questionable or isn't the best, just kindly suggest some credible sources that they should check out instead.
Thank you so much, Ashley. We have about a minute here before I just want to wrap up and thank everybody. I know you and your fellow students have been working on a video for the community. Can you just take about 30 seconds and describe that for us?
Yeah, so if you are located in the UP or happen to go to the movies, you may see the video. Thanks to the Center for Rural Health at Northern Michigan University and the Upper Great Lakes Family Health Center, our video will be shared across the UP on TV and in movie theaters. And again, it's just, it was a class project that kind of evolved into something more, which we're really excited about. But it's just, I guess, full of good reminders for everyone as we continue to fight COVID.
Well, Ashley, I just want to commend you and your team for everything that you're doing here in the department and university and sharing that, sharing those resources with the community. Kelly, I'll give you the last word here. I'll give you about 20 seconds here. What's kind of the take-home message you think for tonight's town hall?
Wear your mask, get vaccinated, get boosted, keep your distance from other people, and absolutely stay home if you are sick. And I'd like to also remind our, especially our students, we are having Winter Carnival is going to be in just a few weeks. Like Luke mentioned, these large gatherings are super spreader events, and it is very hard to tell necessarily, what's going on with you. So we have out-of-towners coming up to celebrate. There's lots of stuff going on. If you are sick or have been exposed, stay home and don't go to this. We don't need to see another spike due to those kinds of gatherings.
I want to thank all of our presenters for tonight for doing their part to keep us safe, for coming on tonight. Thank you to our listeners and our sponsors, UP Health System Portage and the Michigan Health Endowment Fund. We'll be back the final Thursday of February, the 24th at 7 p.m. Have a great evening, everybody. Stay healthy and be well.